I will do it. I'm assuming everyone is looking at my lead-in slide. Before I get started, I want to apologize. I was confused about the start time, and I am usually pretty punctual, and so this is putting me on my heels a little bit, but I really apologize to take all of your time for my mistake.
No, you're fine, Catherine. It is Friday the 13th. We all know that.
Okay, so I today am going to present on using the National Survey on Health and Disability to explore pandemic-related changes to social isolation and loneliness. And I just want to highlight that I've worked on this presentation with one of my colleagues, Dr. Gilbert Gim. So in addition to me, I want to highlight that his work is also represented. I'm going to switch slides and go
Excuse me a minute. Excuse me. Is someone introducing Catherine?
Yes, I forgot. I'm sorry. It is Friday the 13th. Okay. I forgot that.
It is indeed.
If you wouldn't mind letting Roxy introduce you.
Absolutely. That's great.
Go back to your first slide.
Do you want me to sit back down, or do you want me to just stand there?
Stay where you are.
Okay, good.
Not risk that. Roxy and Sue Ellen, could you come up front, please? Sorry, I forgot that. That's my fault. Thank you, Lori Vaughn, for reminding us.
Can everybody hear me?
Yes, loud and clear.
Sue Ellen will be reading for Roxy as she has dyslexia, and I'm helping her out. I'm Roxy Logan. I'm 35. Was diagnosed with remitting, relapsing multiple sclerosis when I was 30. I live in the UK. I've been in Second Life, SL, for 18 years, and I really love art. Run an art sim in Second Life called Rocks Studios that hosts the SL Random Art Crew. In RL, I'm a BA, HONS, undergrad in Fine Art undergrad with the University of Wales in the UK. I also hold an HND, Higher Nation Diploma, in Design and Web Development. Presenter's biography. Today I'd like to introduce Dr. Catherine Ipsen. Dr. Catherine Ipsen is the director of the Research and Training Center on Disability in Rural Communities, RTC Rural. Her research interests focus on improving health and employment outcomes of rural people with disabilities. As part of this work, she has explored social isolation and loneliness experiences of people with disabilities, developed health promotion and self-employment interventions, using the National Survey on Health and Disability to explore pandemic-related changes to social isolation and loneliness. This presentation will open with a description of an publicly available dataset called National Survey on Health Disability and findings related to conventional versus MTurk recruitment methods. This will be followed with longitudinal data analysis from the NSHD to explore the experience of social isolation and loneliness among rural and urban people with disabilities before and during the COVID-19 pandemic. Audience, please hold your questions and comments to the end so as not to interrupt our presenter who is new to Second Life. If it's possible, due to Dr. Ipsen being new to Second Life, we would appreciate our audience remain silent until the end of the presentation. We would like to graciously thank Sue Ellen for presenting this verbally for all those who will have appreciated it. From here, I would like to pass the floor over to Dr. Ipsen. Thank you.
Thank you. So I appreciated the introduction, and that really sets the stage for where we're going to go today. I'm going to pick up where I left off in acknowledgements. I want to say that all the research represented today is supported by grants from the United States National Institute on Disability, Independent Living, and Rehab Research. And there are 3 grants that are represented, one that supports the RTC Rural, one that's supported and has now closed. It was called the Collaborative on Health Reform and Independent Living, and then a grant that has really picked up on that work called the National Survey on Health and Disability Project. As always, the findings and conclusions presented here today do not necessarily represent the views of NIDLR, the Administration of Community Living, or the Department of Health and Human Services of the United States. One should therefore not assume endorsement by any federal government agency. We have to say that always. Okay, so I'm going to start off and just kind of talk just a little bit about what is social connection. Social connection is the experience of feeling connected to other people, and it's a basic human need. So we all know that our support networks help us weather ups and downs. They help us build self-worth by fulfilling the needs of others, and they really help us feel like we matter in the world. And that concept was highlighted by 2 doctors, Dr. Mark Salzer and Brian McCormick, who've done quite a bit of work in mental health and psychiatric disability, and really talking about the role that mattering means in our well-being and fulfilling roles in the world. So a lack of social connection can lead to social isolation and loneliness. And these 2 traits or experiences are associated with worse physical and mental health outcomes, more physician visits, hospitalizations, cardiovascular health issues, depression, anxiety, declines in cognition. It's really hard on people to experience social isolation and loneliness, and they're worthy of paying attention to as a result of that. So I'm shifting slides. I want to just highlight that social isolation and loneliness, why they often go hand in hand, often are experienced a little bit differently. So social isolation is an objective measure that indicates a lack of or limited social contacts with others. So you can kind of think of it as how many times do I go out in the community? How many people am I close to? So it's very objective. Loneliness, on the other hand, is a perception of social isolation or of feeling or being lonely, and it's different. There are many people who really relish or are fine with being alone and spending a lot of time in, doing their own thing and being solitary. These people may not experience loneliness, and similarly, there are people that maybe have a lot of support or a lot of people that they're connected with. They know a lot of people, they have people at work, but they feel lonely or left out. And this can really happen when structural barriers might get in the way of how they participate or those sorts of things. So they are similar, they often move together, but they're distinct. So moving to the next slide, looking at temporary loneliness versus chronic loneliness. So loneliness in general is not a bad thing. It is something that we internalize and signals a need to build new relationships or social connections. And it's an adaptive process. We are built to be in community with one another. It helped us survive kind of in the early days of our evolution. And as part of loneliness, there's something called a re-affiliation motive, or stages across the lifespan that we go through to kind of adapt to this loneliness state. So at first you might have experienced loneliness, and that might be accompanied with a withdrawal from social interactions. Then you look around yourself and you say, oh, who do I want to meet? How do I engage with that person? What are the things, what are the people or directions that I want to go? And based on those, that hyper look at the world, you modify your behavior. You might go to certain places more often, or you might talk to new people, and that helps you re-engage. That is how it works with temporary loneliness. And we've all experienced temporary loneliness when we've gone to a new school, we've moved to a new location, we've started a new job, or something like that, where we're not really in and connected with people yet, and we're working hard to build those connections. Chronic loneliness is different than temporary loneliness, and essentially chronic loneliness, you get stuck in the withdrawal stage, and it can be self-fulfilling or kind of reinforcing. So you might feel shy or anxious or have low self-esteem or depressed mood, and all of these things kind of sustain the withdrawal, and you don't move into that kind of reaching out and trying to re-engage. Also, when you lose social networks, sometimes it can make it difficult to build new ones, and sometimes just people in general have less positive reactions to the environment, and there might be negative interpretations of what people or the social information that you're receiving, and can really make it harder to re-engage and start turning around that loneliness state. Moving to the next slide. Structural and environmental barriers affect and can be more impactful for people with various disabilities. And some of these are things like limited public transportation options. So that impacts opportunities to engage in employment or socialization or independent living. Inaccessible community infrastructures outside the home, such as how to get from point A to B. Are the sidewalks, doors, parks, etc. available to you to begin to make those connections? People also experience inaccessible housing environments inside the home. We did this study where many people with mobility impairment live in homes with stairs, and it's hard for them to navigate inside and out of the home or up and down stairs within the home. And then finally, stigmas can reinforce those structural barriers and increase those feelings of social threats. So together, these structural and environmental barriers can impact confidence, choice, and control in how one participates, and then by default, impact both social isolation and loneliness. So moving to the next slide. Most of the research, and I'm not going to say all, but most of the research to date about social isolation and loneliness has occurred in older adult populations, 65 and over. The reason for this is that many older adults experienced some very significant life changes, retirement, they maybe lose a spouse, they may change homes, they may experience new structural barriers related to emerging mobility impairments. They might have health changes, that higher rates of chronic illness or pain that begin to impact their ability to connect with people and get out in the community. And so they're studied more as a result of that. And there's evidence that the loss of established social networks and supports lead to isolation in about 1 in 5 older adults age 65 and older. And this is according to the National Health and Aging Trends Survey. There's less evidence on the experience of social isolation and loneliness prevalence in younger adults, and specifically with disability and specific type of disability. And that's kind of from my perspective, a problem, because many people with disabilities experience some of these same life changes, health changes, and structural barriers. So I'm going to highlight just some research that, and this is research that Gilbert Gim did, so I don't want to take credit for it, but he looked at the health and retirement survey. And I apologize for all the European and international colleagues out there. All of this data is very focused on the United States, but I'm sure that there are linkages and similarities across place. So anyway, the Health and Retirement Survey is a longitudinal survey of adults that's conducted nationwide, and it starts at age 50 plus. And Gilbert wanted to look at people who are 50 to 64 to really begin to look at comparisons between people with and without disabilities in terms of the experience of social isolation and loneliness. The HRS includes some indicators of disability that are focused on work limitations, activities of daily living, and instrumental activities of daily living. So it's a narrow definition of disability. That's the nature of sometimes using these national data sets. And the important thing that it does have, though, is a measure of social isolation and a measure of loneliness. The measure of social isolation is a 6-item question that you get 1 point for each time you say yes to this, and 3 or more indicate social isolation. And these measures are not being married, living alone, having less than monthly contact with children, other family, friends, and participating less than monthly in groups, clubs, religious services, or other social organizations. So if you can answer, 3 or more of those, yes, that means that you might have a certain degree of social isolation. Then there is measures of loneliness, and in terms of lack of companionship or feeling left out and feeling isolated. And I want to highlight that these items align very closely with it's called the UCLA Loneliness Scale 3-item, and it's something that we are going to talk about and use later in the National Survey on Health and Disability. So let's look at that data just right off the bat. What that data indicates for adult participants age 50 to 64, those who have a disability relative to not having a disability are almost twice as likely to experience social isolation and more than twice as likely to experience loneliness. And that's just to give us a baseline. This is data from, I believe, 2016. So just a baseline is where we're starting in this conversation is that people with disabilities, or at least those experiencing work limitation, ADLs or IADLs, are starting at a place of higher rates of social isolation and loneliness. So we wanted to expand on that. And the further research questions were, what factors predict that social isolation and loneliness experience in people? Is it socio-demographic characteristics? Is it type of disability? Is it environmental factors like where you live or your access to transportation, or do you live with other people, and so forth? And then how did these rates of social isolation and loneliness change due to or during the COVID-19 pandemic? And really the significant change in how we all participated based on the lockdowns in the United States. So I'm going to give you just a little brief overview on the National Survey on Health and Disability. It is a national convenience sample, but it contains only people with disabilities and only working age, so 18 to 64. So while it is a convenience sample and not necessarily representative of the entire population of people with disabilities, it does have an opportunity to really focus in on the working age adults. Also, the NSHD includes many different measures of disability, some of them being functional, some of them being disability type, related to duration. And so it begins to have some questions that really allow you to unpack the experiences of different groups of people. The questions focused on demographics, health status, transportation access, personal assistance services, community participation and social isolation. That's what we're going to zero in on today. Receipt of SSI and SSDI payments, employment status, insurance coverage, healthcare access, and including unmet needs. So it's a very comprehensive survey, and I just want to highlight here that it is available for people to use, and if people are interested in exploring some topics on their own, that is something that I can help you get linked up with. My mouse is not doing, okay. So the NSHD data set has so far, there has been 3 waves conducted, and the 4th wave just started. The first wave occurred in 2018, and then the second wave occurred, or the data was collected, October 2019 through January 2020. And this is a pretty opportune time because it occurred just prior to COVID-19 kind of lockdowns and changes, really instrumental changes across the world in how we participate. Wave 3, which was fielded January through May of 2021, was 1 year into COVID, but before vaccination was available. So it's a really distinct time period to be able to compare responses. And then wave 4, which just started, then provides a third understanding or wave of COVID 2 years out in the midst of vaccination and moving from a pandemic to a, I don't know what the other word is. Not a pandemic, but someone from the audience needs to help me. Endemic?
Endemic.
Yeah, okay, got it. Thank you. Okay, I'm going to my next thing. So I'm going to do an aside, and I hope that I have time for this. I don't even know. I'm not doing a very good job tracking my time because I was such a disaster getting on time, but I am going to do just one sideline about NSHD recruitment. And I'm doing it really as a nod to Alice because she was really interested in a paper that I looked at about these recruitment methods. So initially, the National Survey on Health and Disability began recruiting using conventional methods. And by conventional methods, I mean people were identified through affiliations with disability-focused organizations, groups, conferences, agencies. Although we didn't reach out to Virtual Ability, we very well could have, and also would welcome people to do the survey if they want to from this group. But what happened was we got a sample that was not quite as representative as we hoped it would be. It was an educated group. There were certain disability groups that were not well represented. There were not enough rural people, etc. So during wave 2 and subsequent waves, we supplemented that recruitment through MTurk, which for people who may or may not be familiar with it, it's essentially an online marketplace run by Amazon. And workers, which can be anyone from the population, can sign up to actually look at jobs that are posted and pick up a job called a human intelligent task for a small payment. And what this allows, at least for us, is we could screen people, multiple people from the population. We can screen them for a very small stipend, let's say 25 cents, and they fill out 2 questions for that. And those questions can allow us to recruit them into a survey focused on people with disabilities, because we can use a screening question for that. So we did that. And what we found was that the conventional and MTurk recruitment methods resulted in some pretty different characteristics of the population. So when we looked at the conventional methods, they reported high rates of SSI, SSDI, or both, and that was 36% versus 12.8% of the MTurk group. And then higher rates of physical, intellectual developmental disability, autism, sensory, and neurological disabilities. So the conventional groups really had higher rates of these, and presumably some of this is because they were part of organizations that, you know, represented these different groups. So the MTurk recruitment, which is much more like a population-based recruitment. Granted, everyone has to be pretty savvy to be online, but what we found is that they had lower incomes, they were less educated, they had lower rates of insurance coverage, they were younger, they had higher employment rates, and they had higher rates of mental illness, psychiatric disability. And importantly, less than 10% of the people that were recruited through MTurk had any affiliation to a disability organization or agency. So it really highlights the fact that you're capturing a different group of people, that there isn't a whole lot of overlap. In consideration of time, I'm not going to go through the entire chart about NSHD participant characteristics, except to highlight one thing in particular that is very notable, is that 86% or 85.8% have some college, which is not characteristic of the general population of people with disabilities if you're looking at something much more representative across the population, like the American Community Survey. While I don't weight the data and I acknowledge just the limitations of the characteristics, I want to highlight that there is weighting available with the NSHD data sample. So if people want to use that for that process, that's great. Okay, moving on. I just wanted to quickly go over the social connectedness measures that I'm going to be talking about or looking at in some of the analyses. There are 4 social connectedness measures. I'm satisfied with my current level of leisure activity on a scale from 0, not at all, to 4. I'm satisfied with my current level of social activity, same scale. Then we look at social network quantity. So this is really just a number. How many family members or close friends do you see or hear from at least once a month? That's capped out at 9+. And then social network quality. When you have an important decision to make, do you have someone you can talk to about it? 0 equals never to 5 equals always. The social isolation and loneliness measures so higher rates of the social connectedness measures mean higher rates of social connectedness. Higher rates of the social isolation and loneliness measures mean higher rates of social isolation and loneliness. So you have to pay attention to which ones you're talking about when you're looking at data and directions. But the social isolation, I feel isolated from others in the community, 0, not at all, to 4, very much. And then we use for the loneliness measure a validated measure called the UCLA 3-item loneliness scale. And it has 3 questions. How often do you feel you lack companionship? How often do you feel left out? How often do you feel isolated from others? And the response options are 1, hardly ever, 2, sometimes, 3, often. And these 3 answers are summed together to create a scale from 3 to 9. So I'm going to start by talking about, and I changed slides for someone who's helping me, about the multivariate analysis of loneliness. And what we did is we ran a regression analysis with loneliness scores as the outcome, and we had variables to predict those scores based on socio-demographics, so race, education, gender, age, 138% of the federal poverty level or below, and employment. And then we looked at different disability types, and these are self-identified disability types in psychiatric, physical, chronic illness, IDD, sensory, and neurological. And then we looked at environmental factors, including whether a person's from rural, if they have transportation problems related to daily needs, transportation problems related to social needs, and if they live alone. And what we found, and these aren't hugely surprising, but significant predictors of loneliness were not being employed, having mental illness or psychiatric disability, having transportation problems related to social needs, which importantly, transportation problems for daily needs did not factor into loneliness. So that people who can't access transportation to meet their social needs have much higher rates of loneliness. People who live alone have higher rates of loneliness, and people who live at or below 138% of the federal poverty level experience higher rates of loneliness. The most significant predictor was transportation problems, interestingly. I don't want to go through all the models that we did. I just want to highlight the things that were consistent across the models. And interestingly, not employed in transportation problems and mental illness, psychiatric disabilities were the very common indicators, significant in every model, to either lower satisfaction with social activity, lower quantity of contacts, lower quality of contacts, but increased loneliness. So those are the consistent ones that fell across all those models. When you look at things like living alone impacted your quantity and quality of social contacts and loneliness, but really was not a significant predictor of social activity. So these kind of begin to look at some of the different aspects or predictors. Rural location, which we're always interested in, impacted only quantity of social contacts, but really didn't have any bearing on these other kind of indicators of social connectedness or loneliness. So that begins to speak to some of the differences in those domains or of loneliness and social isolation. So then we wanted to really think about the COVID-19 pandemic and how that might impact social isolation and loneliness. Prior to the pandemic, social isolation was cited as a public health crisis. So in 2017, the U.S. Surgeon General at the time called the rising prevalence of social isolation and loneliness a public health epidemic. March 2020 happens, lockdowns, mandatory social distancing. That begins to really impact social isolation, loneliness, and the combination of social isolation and COVID-19 was referred to as the double pandemic, that these two things are happening at the same time. Social distancing, stay-at-home orders, job loss, declining services. I mean, we just did a paper on the loss of long-term services and supports during this period, and it's just horrendous how people's quality of life and ability to participate in their communities changed significantly. I also want to highlight that impacts were not equally shared across groups, and high-risk groups experienced more intense impacts in the choices that they made to participate. Older adults, people with disabilities, people with pre-existing health conditions, etc., had to pay attention in a different way because the consequences were greater. And it really exacerbated prior health disabilities. So how did we want to look at this change of social isolation and loneliness over time. Well, we were able to use wave 2 and wave 3 of the NSHD, which I highlighted prior to that, really occurred right before COVID began, and then 1 year into COVID, but before vaccination rollout had occurred. And there were 566 people who provided data at both of those data points, and we were able then to track their experiences of social isolation, connectedness, and loneliness over time. And what did we find? Well, first, and this is a bar chart showing pre to post COVID ratings of social connectedness. So these are the same people over time. And what we found is that over time, there were no significant differences or different changes in their ratings of social connectedness, with the exception of their rating of leisure, which they actually said improved. So social connection was not impacted for this group of people with disabilities pre to post COVID. And I want to say, yeah, we're never going to get to post COVID, but for us, it means after COVID began. It's a little bit like AD. Okay, then pre to post ratings of social isolation and loneliness. People reported significantly higher rates of isolation or not being out in the community, but they actually also reported significantly lower rates of loneliness over time. This is very, very different than the general population, where rates were kind of going off the charts. So remember, first of all, people with disabilities started at a place where they were experiencing higher rates of social isolation and loneliness prior to the pandemic, but actually the pandemic did not have the impacts that we would have expected. So what is happening? The rates of social isolation usually move together. It was untrue for the NSHD sample. The social isolation increased, loneliness decreased, and what are some of the possible explanations? Okay, one is the subjective nature of loneliness. Everyone is in the same boat, so it might lower the feelings of being left out or excluded. Another explanation is there are new ways of connecting that are emerging, and there was really a huge transition to online socialization, and as people got more comfortable with that, it's possible that they reduced their digital barriers, much like me getting on Second Life, and then, had new opportunities open up to them. Another explanation is reduced structural barriers. So remote work. There was reduced stigma for attending meetings online or not being in the office fully present all the time. And so these are important things that maybe explain this outcome. They also align with some voices from the field, and we do a lot of work with Centers for Independent Living, and there were ongoing kind of support like network calls among different CILs, and we use some of these to really highlight some of what we kind of saw was happening. So one is a quote, it says, "I think these isolating lockdowns are bringing a large number of people, almost all at once, into our disability community through a shared experience, which is incredibly unique." So these shared experiences of everyone being in the same boat really may have helped keep people from being left out. And then CILs have scrambled to provide accessible ways for consumers to connect, for peer support, both virtually and in person for those without technology to combat social isolation. So CILs are actually a vehicle that are helping people connect online, and the CILs and also vocational rehabilitation have used CARES Act money to provide technology to people maybe who didn't have it before, teaching digital skills, holding meetings on Zoom, and then people taking those skills and being able to use them in other domains. So I'm just going to go over just a quick summary of the key findings from the NSHD. Social isolation got worse after COVID, but loneliness did not. Temporary social isolation can lead to loneliness, but SILs might be playing a really important role in overcoming these temporary social isolation experiences. And telecommunication literacy and access is super important, and it's a great vehicle to overcome that, particularly as we see these kind of waves come and go. As people build these skills, it's really important. Chronic loneliness might require more comprehensive programming for people to overcome it. And I see, and we've actually done a little bit of work exploring the role of Center for Independent Living peer support models, both in person and virtual, to really address some of these things. Building self-determination and self-confidence, creating roles for mattering, because in a peer support group, you're both a teacher and a learner, creating more opportunities to socialize and build a network out, and then building inclusive networks, and this is more of an advocacy end of it, to overcome and address structural barriers that might exist beyond your own social network. And then finally, employment and transportation access are protective of those experiences. So thank you. I'm sorry that was a huge rush and I was late and probably someone's waiting, but thank you.
You did great, and there's absolutely no reason to apologize. It is Friday the 13th. What do you say? This is Gentle, and I do have a question. I wonder if what my mother used to call young adults these days have a different approach to loneliness and being alone than young adults did in the past. I'm specifically thinking about the lying down movement, and that started in China as Tongping. For those who are not familiar with the lying down movement, these are young people who opt out of everything that's adult. They opt out of marriage, they opt out of employment, and the reason is because they think the good life is unattainable. Have you worked with any of these kinds of young adults?
I have not, but I do know that there's recent data that came out from the Behavioral Risk Factor and Surveillance System, which is a national survey here on youth, and the rates of loneliness and pretty kind of severe depression rates are skyrocketing right now, up to like 40% of transition age students, and this is the general population. And so I think that this idea that the good life is unattainable is really pervasive. But I'd be interested to learn more about that. That sounds super interesting.
Does anyone else have questions for Dr. Ipsen? I see a lot of clapping and applause. Wonderful presentation, thank you. Turn this back to Lori Vaughn.
Oop, we have a question from Claris. One moment. What sort of demographic, I don't know, chimeras have you seen with social network developments caused by COVID?
I don't know what.
I don't know what that means either. Claris, could you clarify?
Polaris, if you like, you can speak.
Hybrid, okay. Demographic hybrids.
I'm still not quite getting the question.
No,
I'm
please
sorry.
clarify a little bit more, Polaris.
Mm.
So I guess where they overlap, that might be where Polaris is talking about.
Right. I'm not sure. Well, yes, I think that there are definitely interactions, and although we didn't explore interactions per se in the data that we presented, if you think about even the multivariate model that I showed and some of the beta values, which this might be confusing without having that data right in front of you, but having lack of, if you were someone who came from a had like multiple traits in terms of not being employed, being at 138% of the poverty level, not having transportation to get to your social places, etc. All of those things build together to lower or increase your feelings of loneliness. So if you have multiple characteristics, that would happen. On the other hand, there are also things called interaction terms, which we didn't explore very closely, but then actually even have an elevated element of increasing those things. And I can't really speak to them because I don't have that data, but it's quite possible that there's even additional impacts of having two or more of different traits beyond the independent factors.
Let's see, I see a comment from Marley. There was an article in the Times, she thinks, which outlined the characteristics of people like herself who are unaffected by social isolation or loneliness. One thing she would be interested in seeing as part of your research are surveys about inner resources people have which make a difference in the way they deal with isolating events in the world.
I think that that's true. I think that each of us have different kind of points with which we start that journey, and you know, it's kind of, you can take two people with really similar experiences and conditions, and they have different traits that one person doesn't perceive something as a threat and another person does, and it can shape how you experience isolation and loneliness and moving through that condition. I'm not keeping up with all the comments, but I have seen some things that are, I think, super interesting about the return to normal. I guess that was one of the comments that stuck out for me, and you're right. I actually think that there isn't going to be a return to normal. However, I think that some of the opportunities and changes that have come about as part of the pandemic will really carry forward and potentially essentially keep some of those opportunities for connection open based on online sorts of changes, specifically for work and also just how we communicate with family and friends. So I mean, just personally, I never used Zoom to talk to any family member before the pandemic, and now we do, and we see each other, and I see my nieces and nephews and that sort of thing. So
Roxy says, just 1 minute. I don't have a question. It's more of a statement, sort of a question, I guess. I'm in my mid-30s and now being a student, I've found a lot of others of similar ages or older and younger who have reached out to make friends with me because we all have pandemic isolation in common. We've all had to be so careful with use of the internet and safety. Is that represented in your studies or the data in any way?
I absolutely think it is. I can't say for certain, but when you have things like people are saying I'm more isolated from people in my community, so that was significantly higher, but you're saying, but I'm less lonely, there has to be something about how people are communicating and connecting with one another. So
Okay, thank you so much. We're going to leave it there. But first, a comment from Sidearm, who gives a cheer to Missoula, where his dad and uncle grew up and went to school. So, university cheer.
All right. Well, thank
Yay,
you. I
Montana.
appreciate
Thank
it,
you.
and sorry for the delay getting here. Have a good day.